diabetes for 35 years, 35 and a half, and I have 5 children. I've had 7 pregnancies and 5 live births. I've had experiences anywhere from natural conception to medical intervention for medical reasons. So a lot of experience there. And I've worked closely with Dr. Marina Basina over the years. And so we've been doing the Sugar Mommas for about 8 years now. And you can find support online on Instagram at T1D Sugar Mommas. It's MOMMAS. And we have a website coming out really soon. So we want to build our community and support. So you can check out more information for diabetes and pregnancy there at www.t1dsugarmamas.com. I apologize if you hear my kids screaming now in the background, but that is life. We have a great medical advisory board on our team, so you can check that out when the website comes up. And I will let Dr. Basina introduce herself.
Hi, everyone. Welcome to the session and great to see you all. I think we met some of you yesterday, and it was an exciting session yesterday, so I'm hoping for another exciting session today. It's the last day of the camp, and I think it was great yesterday. We had a really, really great sessions. I am Dr. Marina Basina. I'm a adult endocrinologist at Stanford with a special interest in pregnancy and type 1 diabetes because of my former background as being as OBGYN for some period of time in my former life. So I'm all passionate about pregnancy and now a combination of pregnancy and type 1 diabetes. And we're happy to host you here with Brooke. She's been instrumental with getting the group together and getting the website together. She's been amazing. I don't know how much energy she has and where does she find all the energy with all the kids.
Thank you, Dr. Basina. Now, Dr. Basina, did you want to start off with preconception phases of pregnancy and diabetes?
Sure. I think, as always, I prepare a lot of information, so feel free to interrupt me at any time point and ask questions. So I'm just going to share my slides and do the slideshow from start. All right. So I try to make it more sort of user or easy to understand. So because I think it's a great and exciting time during women's life, and exciting, and on the other hand, it's complicated and anxiety provoking. So I just want to walk you through that from the planning stages to the breastfeeding. That's what we're going to go through. So the first mention of the pregnancy and diabetes, and it was more of the gestational diabetes, was back in 1989. That was officially in World Health Organization addressed the mission of International Scientific Diabetes Community. So the idea was to dramatically reduce the risk of diabetes women complications to the level of non-diabetes. And again, they was more addressing the gestational diabetes for early diagnosis and for prevention of all the complications by taking by control early on. Now with type 1 diabetes, now it's fairly common to be pregnant, and it's a norm in the OB world, and it's not something unusual that used to be maybe 30 years ago. And now roughly 1 in every 300 reported pregnancies is the pregnancy in women with type 1 diabetes. So what are the challenges in order to get pregnant, to conceive? So there, overall, there is an increased incidence of type 1 diabetes, either because we're just diagnosing more, because we have more of the tools for diagnosing and getting the antibody tests, but more and more women obviously will be getting pregnant. But it's important to do it early in planning for pregnancy, because unfortunately, about 40% of type 1 women will have some menstrual irregularities, so it's common. elevated androgen level or male hormones. And women can go into early menopause because it's part of the autoimmune condition. And why is that happening? It could be a combined effect of not having enough insulin and, in addition, having higher blood sugars. But it has been shown that intensive insulin therapy improves the control and improves the reproductive function. And insulin actually is regulator of the brain and ovarian axis. So there is, it's well known that women fairly frequently with type 1 diabetes have delayed in the onset of the menstrual periods. So if you look at this graph, it was done in total of almost 230 female. Some had been diagnosed as diabetes early on before they had started having periods. Some diagnosed after they started periods, and compared to women without diabetes. What it showed is that women who were diagnosed before the onset of the menstrual periods actually had later onset of the menarche or the first period than in women who were diagnosed after the menarche or onset of the first period, or in control of women who did not have diabetes. And menstrual irregularity was found to be in about a third of the women with type 1 diabetes. So what are the other reproductive abnormalities due to the excessive insulin administration? So again, we talked about that yesterday, and it's always the case that unfortunately the insulin that administered subcutaneously, it's in quantity, if we compare it to the amount of insulin produced in women or in the individual without diabetes, that is always in excess, right? Because you're trying to suppress liver production of the insulin, of the blood sugar, and bringing those extra glucose into the blood with the insulin that's delivered subcutaneously. And usually if pancreas produces the insulin, then it goes straight to the liver and suppresses the liver. So whatever insulin we're giving, it's always, if we quantify it, it would be more than it produces in an individual without diabetes. So because of that, because of this excess of insulin, so some tissues in the body are resistant to insulin, but some tissues in the body are actually really sensitive to insulin. And it turns out that ovaries are sensitive to insulin. In the ovaries, there are the cells that produces the male hormone or testosterone. And what happens is this excessive amount of insulin increases the growth of those cells that produce testosterone. And that's why elevated testosterone is not uncommon in women with type 1 diabetes. Because of the higher testosterone level, because of the higher level of some insulin resistance in women with type 1 diabetes, there is common condition that I'm sure you've all heard, polycystic ovarian syndrome. So this is one of the most common abnormalities, hormonal abnormalities in women of childbearing age, but more so common in type 1 diabetes. And again, subcutaneous insulin administration does not get straight to the liver, and that's why it exposes the tissues to supraphysiologic, to higher levels of insulin that should be normally present. So I'm not going to walk you through the whole diagram because it's complicated, but just to focus on some. So again, insulin administered subcutaneously causes the higher insulin level, increases the ovaries to produce testosterone, increases the ovaries to make the cystic appearance on the ultrasound. The insulin deficiency also leads to decrease of the hormones in the brain that stimulate ovaries to produce estrogen and progesterone. And therefore that can cause the low gonadal function, low ovarian function. There's also an effect of high blood sugar with glucose toxicity, insulin resistance, and exposure of the tissues, especially ovaries, to the higher level of the glucose. So again, ovaries are sort of in between the two sort of attackers. One is the insulin, the other one is the high blood sugar.
Dr. Basina, pardon me for interrupting, but this isn't a guarantee, just to make clear for
It's not a guarantee. It's just
No.
more common in women with, yeah, definitely not guaranteed. Nothing is guaranteed in our life, but
Right.
it's
I just want them, the moms to realize it doesn't mean that this is for sure going to happen. There are still women who live with type 1 who have normal cycles and are able to get pregnant more easily, and these things
Oh,
don't
absolutely, for sure. Yeah, no, for sure. That's for sure. It's just what I'm trying to explain is that, you know, things, it's not that there are some things that we can control, but are some things that we cannot control necessarily. But we'll get to the pregnancy, and yes, absolutely, women can and have normal pregnancies. So
Any other questions up to this
yeah.
for Dr. Basina about this information? No? Okay.
All right. So again, PCOS, or polycystic ovarian syndrome, is more common in type 1 diabetes than in non-type 1 diabetes. So there were some studies looking at metformin. You know that metformin is used widely in type 2 diabetes, and there were some studies looking at metformin in type 1 diabetes. And interestingly, for preconception, it had been shown to be effective in some women. So that's something that we have in our treatment options to give it. And I have some anecdotal reports for my clinic when even women had difficulties getting pregnant with metformin. Women got pregnant within the next few cycles and everything was perfectly fine. Again, those are anecdotal reports.
Can you explain how the metformin helps?
Yeah, so the metformin works by decreasing the liver production of the glucose. So because of liver puts out less glucose, there's less insulin needed to cover that glucose, right? So their insulin doses get lower, right? So on some, it doesn't happen in 100% of women, but in the studies, it showed that metformin therapy can reduce insulin requirements by 20 to 25%. Again, it's not in someone who is already super insulin sensitive. It's someone who is maybe taking excessive amount of insulin per the body weight. Again, we talked about this yesterday a little bit, that average type 1 individuals, it takes about 0.5 to 0.55 unit per kilo per day. So if you're taking more than that, then you may possibly benefit from a little bit of metformin. It may be challenging, but it's in reproductive function is it can be affected throughout the lifetime, but it's definitely possible, and it's definitely happening in we're having increased rate of pregnancy and successful pregnancy. So we'll get to that. What are the increase of the risk? Again, my talk today is not to make you more anxious about it. It's the other way around. It's actually try to encourage you that it's not impossible, it's possible, and it's should be a great experience. But they are just to be aware of some factors that the challenges that may be happening. And because of this challenging, what I want also the outcome of this talk is that for you not to think that I'm doing something wrong. I'm not doing enough work to make it happen. It's just the physiology. So you're doing everything you can and you're doing really great. So preterm deliveries are more common in type 1 diabetes than in pregnancies without diabetes. Preeclampsia could be more common. The stillbirth can be more common as well. Macrosomia, it's actually very interesting because for whatever reason, unknown to us yet, it's even ideal blood sugar control during the pregnancy. The babies still can be larger for gestational age. But it's more common in pregnancies with diabetes, in any diabetes, not just type 1 diabetes.
So can you define macrosomia then? Is that just being the larger abdomen and?
It's larger for gestation, larger, I think it's over 4 kilograms at birth. That's the definition for macrosomia.
I think one of the big important things to know about for a woman who lives with type 1 is that you also need to take into consideration genetics and things like that when the baby, like when they're doing measurements, because I see a lot of women comment, oh, my baby's big. And they've even said that to me, oh, it's because of your diabetes. And I said, my A1C was 5.2 in my pregnancy. How is that possible? And then my fourth child, when he was 3 months, was in 12-month clothing. So he's just always been big. So it's really to always, take into consideration multiple factors. Dr. Basina, for the preterm delivery for these women, is that rate of people who not go into natural preterm delivery, or is this generally inductions, or because there's a reason, like real diabetes related? Is that why it's done earlier at this percentage?
No. So it's not that, that's not considered preterm delivery that women are induced early. So those are considered for women who went into labor early.
Perfect, just for clarity.
Yep. And again, large gestational age, again, it's more common in diabetes, but it can be non-diabetes. Our nurse in the clinic, she delivered 2 babies who were both over 10 pounds, and she has no diabetes whatsoever. She had normal. So it's, yes, it's genes definitely play a huge role.
And then from what I understand, but if you can clarify for the women, so not to freak out, because when I see stillbirth, it still makes me go, oh, if you're well controlled, the chances are still, I mean, they're there, but they're fairly low. Is that correct?
So all these complications are definitely increased in uncontrolled diabetes for sure. So with controlled diabetes, all those complications are reduced significantly. That's absolutely the case.
Perfect. Thank you.
Yeah. So what to expect at the preconception visit? So if you're, it's a good idea, I think, to choose your team and to decide, which OB group you will be going with for your pregnancy, for your pregnancy journey. And it's good to meet with the group even before the conception. I have a lot of women who would say, I want to go and have a preconception visit because I want to see what the group is, if I like this group, the educators, the nutritionists, and the doctors, or if I want to look for somewhere else. And it's useful to decide what would be the mode of insulin delivery. Would it be the pump? Would it be the multiple daily injections? Or would it be what insulin type to be on? Would it be considering intensification of management of a diabetes to try to get to A1C? We talked about this yesterday, under 7%, okay, if you can achieve 6.5 without significant hypoglycemia, that's desirable. Looking at which medications you are taking. Some people are already taking cholesterol medications. Some people do have, some women may have the high blood pressure and taking some antihypertensive medications. So some of those medications contraindicated during the pregnancy. So the doctor will switch you to different medications. Again, re-education for the low blood sugars, for the correction of the high blood sugars, not to overcorrection and so on. Assessment of thyroid function tests. So that's important because any individual with type 1 diabetes is at risk, high risk for thyroid dysfunction because of the autoimmune process. Starting the folic acid, that is important too, to start 400 micrograms per day before the conception. And looking at all the exams before the pregnancy, that's important. We talked about the eyes yesterday, so to look there, to do the retinal exam and to see if there are any changes in the eyes before getting pregnant, right? Because we talked about this yesterday a little bit at the session that if you're going from uncontrolled diabetes to very tight control, that does increase your risk for developing some eye complications. So starting early is important.
Dr. Basina, can I ask a first question for education of all the women and families here? In regards to having your thyroid in normal range, there is a reason for that it's important, that's even a little bit tighter than what the normal standard range would be. Can you explain why that is and how our thyroid affects the developing fetus?
Yeah, sure. So because type 1 diabetes is an autoimmune condition, the thyroid disease, hypothyroidism or hyperthyroidism are also an autoimmune condition. If woman has the antibodies against the thyroid for, let's say, to develop the underactive thyroid, the pregnancy itself increasing the requirements for thyroid hormone. So if someone has the predisposition to thyroid disease, if someone has already the antibodies present, then thyroid may not be able to adapt to the increased requirements of thyroid hormone during the pregnancy. So if that is happening, then during the first trimester, the thyroid hormone levels can go lower than they need to be for baby's development. And baby's thyroid starts functioning at about 12 to 14 weeks of gestation. So before that, baby is dependent on mother's thyroid hormone for the development. So that's why it's important to look at it. There were even studies looking at, is it worth it to check the thyroid antibodies in everyone, in not just diabetes or non-diabetes, in everyone, in all the women before conception, because the same thing applies to women without diabetes, but with any other autoimmune conditions or even non-autoimmune conditions, because hypothyroidism is fairly prevalent. Did I answer your question?
Yeah, absolutely. I just want to make sure, because I've had women in the past, you know, come in with really high, and they haven't understood why it's good for their thyroid to be in a good
yeah,
level.
and as you mentioned that there is specific target, is if normal range for in general would be for a TSH to be under 4. For pregnancy, we're targeting for TSH to be under 2.5. So we want the levels to be lower than before the pregnancy. Again, because of that increased demand that body has during the pregnancy to supply thyroid hormone with to the baby.
Thank you. Does anybody else have any questions thus far for Dr. Basina? No, let's keep going. Thank you.
All right. So they are specific stressors for preparing for pregnancy and during the pregnancy. Intensive glucose management by itself is stressful, as you all know. There is increased risk of low blood sugar, and there is a fear of losing your own control because someone else is trying to take control, or where as a healthcare provider is trying to control as best as we can. Anxiety and guilt that something that I'm not doing, my blood sugar today is high, am I hurting my baby? So that's, I'm sure, always in a woman's mind. And what is my meticulous planning for my daily activities and for my food intake? And if I already have another baby at home, then it makes it even more complicated. And frequent contact with us, with a healthcare provider, that can be stressful too, right? Because some women like to be more independent, and during the pregnancy, you're going more frequently for OB visits, for endocrine visits, for diabetes educator visits. The worries about feeling judged. Somebody is always looking at the blood sugars and thinking, oh, this is high or this is low. Why is happening? And taking away this joy of overall pregnancy, just constantly thinking about it. Many women report negative interactions with their healthcare team. So that's why I think it's, again, important if you're planning for conception to see your team, to meet your team before, and to make sure that you're happy with the team. And it is important to have multidisciplinary team. It's important to have social support. And I think sugar mamas are instrumental in that, because it's so important to just run it by someone. This is what I have right now. And this is what my doctors told me. Did you have the same experience? Or I'll tell you the funny story. It's actually 2 sugar mamas that were pregnant at the same time, and they had some difficulty in control. They both did wonderful, and babies are super cute now. But they were anxious during the pregnancy, and we were on email literally daily, and every day they didn't know each other, and I couldn't say anything, obviously, because of the HIPAA. I didn't want to introduce them, but I didn't want to, tell the names or anything. And it was so interesting that every single day they were sending emails within a minute from each other. And I thought, goodness, how do they sense each other? It's literally, I'm getting one email and 2 seconds later, I'm getting another email, exactly the same. Even if it would be a different time of the day, it would be still one after another. And I told each one of them, I said, how do you in the world sense each other? But I didn't tell them their names. And then when they met on Facebook on Sugar Mamas, they said, then the next time they saw me, they said, okay, and now I know who you're talking about because we met on the Facebook. So it's, and then they were, when they were coming for appointments, they try to actually make it on the same day so they can go for coffee after this. So that was a lot of fun. I think that was, and they had a baby within like a week from each other, and they're still communicating really close.
That's awesome. I think what a big important thing to add to that when you pick your medical team is that when I first picked my very first medical team, I ended up going to a learning institution in San Francisco. So I didn't understand what that meant at the time, but there were fellows and residents, and there was I didn't have quite as much consistency of care. So wherever you go to find out, you know, will you always be seeing the same person? Those are really important questions. For me, I like to have a relationship with my doctor and know who I'm dealing with. And so having the rotation and then every quarter, that was a bit more difficult for me personally. So just something to look into.
Yeah, great. All right, so what are the targets during the pregnancy? The targets are quite tough and demanding. It doesn't mean that those targets need to be met 100% of the time, but that's what we're trying to aim for. For the fasting glucose to be less than 95, for 1 hour post-meal, and this is the main number that had been associated with the outcomes of the pregnancy, is this 1 hour after the meal to be under 140, and you can imagine how hard that is, and 2 hours to be less than 120. So if you look at the glucose metabolism during the pregnancy, so we call it accelerated starvation and facilitated metabolism, meaning that the blood sugar really spike right after meal. But because baby is getting the sugar, right? So babies very quickly consume that sugar. And this is accelerated starvation, blood sugar drop. You can see way below in between the meals, and especially during the night, lower than the pre-pregnancy. And that's why this fasting blood sugar target was chosen. Again, we usually say that babies like second brains, and babies take about 6 milligrams per deciliter per minute of your sugar. So the insulin does not go through the placenta, but it's the sugar that goes through the placenta. So that we talked about the A1C target for pregnancy. So because pregnancy is a state of hemodilution, so the blood is more sort of dilute, there's more fluid overall. Amount of fluid, therefore it's because of the dilution, A1C is sort of falsely lower, but because there is a little anemia always during the pregnancy, so that's because of that, the A1C target is lower, right? So it's not, if we would have measured the same blood sugars during non-pregnancy, the numbers will be, the A1C would have been higher. But because of the false sort of drop of that A1C during the pregnancy, that's why those targets have been chosen. So it's less than 6.5 during the first trimester and less than 6% during the second and third trimester, if can be achieved without significant low blood sugars. And it is difficult, it's complex control, and it's stressful, especially now with coronavirus. Everyone is stressed out about possibly getting a coronavirus. And again, as we talked yesterday, that this is not going to go away in the next month or two. This is probably going to stay with us for at least a year or longer. So that will be always a concern. So how do we assess metabolic control? So again, because usually blood sugars are lower and because this starvation happens at lower levels, or even the ketones in issue becomes more important. So for ketones, the recommendations are to test blood sugar, to test ketones, either blood or urine ketones, if blood sugar is over 200. So hemoglobin A1C checked at the initial visit, and then once a month until the target is reached, and then every 2 to 3 months. And then, so there's a lot of telehealth that we're doing now with the pregnancies because of the trying to avoid the contact with the hospitals and the least possible, exposure to the hospitals for women during pregnancy. Therefore, telehealth now, teleappointments or video appointments became very, very common. So DKA during the pregnancy develops faster because of that higher ketone level. And so it had been shown that high levels of ketones associated with adverse outcomes. So again, this is high level of ketones. The mild to moderate ketones are common during the pregnancy, because of that accelerated starvation. So that's starvation ketones. So it's not uncommon for women to wake up with mild to moderate ketones. Those ketones are okay. They're not adversely affecting the pregnancy. So with the weight gain recommendations during the pregnancy depends on what's your weight starting the pregnancy. If you're underweight with body mass index less than 18, then the recommended weight is about half a kilo or 1 pound per week. If it's when women normal weight with between 18 and 24 BMI, then it's about a little less than a pound per week. And if the woman overweight, then less of the weight gain during the pregnancy is recommended. So what is the dietary recommendations? And usually when we talk before conception, what I usually suggest women just try it and start it before conception, because I think it's good to know what this 175 gram is, because you could be either carb eater or you could be non-carb eater. And again, the carb amount is important for the babies because babies do need sugar. They get sugar only from the mom. They don't have any other source. So their studies had been done with a moderately low carb diet with 40% of the calories as carbohydrates. And the current recommendations take 175 grams of carbs daily. For some women who used to have lower carb diet, we're saying 150 probably okay, but we don't have that data. So having approximately, planning for your pregnancy plate and starting it before and trying what is the 175 grams during the pregnancy? How do I distribute it in between the meals? And distribution throughout the day is important because you don't want to have a huge carb load at one meal and then not on the other meal. So we recommend about 20 grams of carbs with breakfast. Again, breakfast usually the time when women are most resistant to the insulin and most carb sensitive, meaning that the sugars spike faster because of the effect of the hormones. 20 grams with breakfast, 40 grams with lunch and dinner, and snacks are important. So snacks in between the meals. Again, you remember that graph that I showed you, that blood sugar drop lower in between the meals. And especially the snack is important before bedtime because whatever liver is able to produce during the night, babies get it really quickly. And then if you don't have the meal or snack before bedtime, then you're waking up with this ketones in the morning, starvation ketones.
I think it's important to note that it's like, if you can't hit that 20 grams of carbs in the morning though, it's okay. I always ended up only being able to eat scrambled eggs, and I was taking 5 or 6 units for a scrambled egg because I had so much resistance in the morning. So it's not a be all end all, and you can work with your certified diabetes educator or doctor to figure out where you can, readjust those carbohydrates.
Yeah, for sure. So not all insulin is approved during the pregnancy. For the longer acting insulin, Lantus, Apidra, and Degludec or Tresiba have not been studied during the pregnancy. We have not been using. So it's Levemir and NPH from the long-acting insulin. Humalog and Novolog have been studied and saved during the pregnancy. It would be great to choose or to study inhaled insulin during the pregnancy because it acts so quickly, but it hasn't been studied yet. So insulin requirements during the pregnancy. For the first trimester, it's actually decrease in the insulin requirements. And it starts anywhere from 7 weeks or closer to 8 to 9 weeks, and it can last up to 14, 16 weeks. And reduction could be fairly significant and up to a third or 30 to 40% reduction in the insulin requirements. And that's the time when low blood sugar is the most common. And second, third trimester, basal insulin increase requirements start increasing from 16 week and onward, and adjusting both basal and based on preprandial and based on postprandial blood sugar is important. And then the levels start coming down. So the insulin requirements start coming down after about 36 weeks because uterus starts exercising, developing some contractions, and consumes that extra glucose. So for the carb ratio, there is about 4 to 6 fold decline, meaning if your number was 1 to 10, it could be 1 to 4. And somebody said yesterday that they were 1 to 1, and that's common. And someone who is an insulin pump, I was talking to one patient today, so we changed her pods frequency change to every day, single day, because she's in her 3rd trimester, she's using the Omnipod fits the 200 units, right? So she's using 150 units per day nowadays. So the pod doesn't last for more than a day. So we changed her prescription to daily changes of the pod. So that's not uncommon. And insulin sensitivity factor, that's again how much 1 unit drops the blood sugars, also reduces from anywhere from whatever you started with. So if you started with 1 unit for every 60 points, it could be 1 unit for every 30 or 20 points by closer to the end of the pregnancy. So possible explanations for the reduction of the insulin requirements for the 1st trimester is hormonal shift. It's previously women who may not be well controlled now are perfectly controlled. So usually pregnancy is a great time when everyone is trying to do their best. And it's important to do this and to get even under control before the pregnancy. So that's important. But again, taking more insulin before the pregnancy can contribute to more blood sugar drops during the 1st trimester. So by Dr. Jovanovic, you might have heard her name. So most of the studies in pregnancy were done by her. She was a professor at USC. She passed away about 2 to 3 years ago. She was in her, I think, 70s or like late 70s. Her whole life, she was starting type 1 diabetes in pregnancy. That was her passion. So on the meetings, she was given a lot of talks. She was amazing. For the 2nd and 3rd trimester, the insulin requirements increase due to resistance. So it's placenta. It's the major organ that makes this hormone, that called placental lactogen, that acts as increasing the insulin resistant hormone. So again, both basal insulin and mealtime insulin reduced, its sensitivity reduced significantly, and requirements go up significantly throughout the pregnancy till about 36, 37 weeks. I guess I'm gonna skip that a little bit just for the sake of time so we can have time for questions. So for the insulin delivery, for the insulin during the delivery, I know everyone has different experiences, and you all have, some women really want to stay on the pump during the delivery, and that's fine. So it's per institution. So I think whatever institution have the protocol, and you should check with your institution where you're going to be delivering before to make sure that that's what you're okay with, and if this is something that matches your requirements or your expectations with what the institution has. So a lot of institutions advise to have IV insulin infusion during the labor and delivery. The reason for that is that tight glycemic control is important. So for the delivery, the blood sugar target to be 80 to 110. And it's just easier to achieve it with IV insulin because half-life of IV insulin is several minutes. Therefore, the titration of IV insulin is just easier to avoid lows and to prevent the highs. So this is the only reason that we have it. And at Stanford, we do have the policy that women need to go on IV insulin during the delivery. And some women really attach to their pump and they want to have their pump. So we are okay to just leave low basal rates with the pump in addition to the drip. For the insulin dosing, interestingly, that requirements decrease during the induction for up to 50% lower dose because the uterus contraction. And the most interesting that after the delivery, some women actually don't require insulin. The ones who had diabetes for since their childhood, and the ones who were checked and they were not making any insulin. There is such a phenomena as becoming insulin producing after delivery. So that's a nice period of time. Then for a few days, you may just become insulin independent, which is great to get a little break from that. So for ADA, the recommendations are for pregnancy to have more than 70%, to spend more than 70% of the time between 65 and 140. Again, it's not 100% of the time, it's 70% of the time. And to have less than 5% total of lows, and to have less than 25% of the high blood sugar. So this is for recommendations for American Diabetes Association. So again, we talked about the active labor, reduction of the insulin requirements because of the exercising uterus, increased risk of hypoglycemia. Some of the hospitals actually start IV glucose because insulin requirements go so much down. And for elective C-section, also insulin requirements go down by up to 50%.
I'd like to interject on a personal experience there. I'm one of the rare people who had an opposite effect, that for some reason I had so much stress, and when my uterus was contracting, that I got upper back contractions and they went down my arms. Therefore, cortisol levels were increased, and I ended up needing more insulin throughout my deliveries, which is not the standard. So even when I had somebody during one of my deliveries trying to control my pump, they were quite shocked and not understanding why I needed more, and they were afraid to give me more at that time. And by my 5th pregnancy, I think I found for myself that having the insulin drip was much more relaxing, as long as you can work with your medical professional to find out where your insulin needs are by your 3rd trimester, because the biggest challenge I've seen for women is they go in and said, well, I did that and it didn't work, but a lot of times there are standard dosages that are just, in the book that they do for everybody, but it needs to be, something where you advocate for yourself and you say, okay, but doctor, these are my current requirements right now. Can we take them into consideration while dosing me throughout the delivery? And when I did that, we had extreme success in regards to my blood sugar control compared to the time I was just on everybody else's regimen, the standard protocol.
Yep. And to your point is that subcutaneous, that's also to make a point for the insulin drip, is that the absorption of the insulin may be different, right? Because there are medications used for induction, the oxytocin and different, that can cause some constriction of the blood vessels. So your absorptions from subcutaneous tissues could be less predictable. And that could be possibly one of the reasons that insulin requirements, were going up if you use the insulin pump. Again, it's not 100% for everyone. Everyone is so different. But again, this is just my point for us to make it more easily to control and faster to achieve that control. That's why we use IV insulin recommended. Yeah. Just for that reason. Again, the absorption through subcutaneous tissue would be variable and not as consistent during the delivery.
Right.
And again,
in mind with all the gel, trying to keep the baby on monitors, they kept falling out. So it's about where you can have it located. It's everybody's different, but it's just it's the reason to talk to other women about their experiences about it and what worked for them.
Yeah. But again, to the point also that not to stress out if the doctors tell you that we would recommend going on IV insulin. This is just for those hours of the delivery. So you're going to go back to the pump as soon as you deliver. So what I was mentioning before, so there is an apparent transient insulin independence after delivery, which is very interesting, and it may last up to 24 to 72 hours. And again, Dr. Jovanovic studied that phenomena, and looking at the type 1 diabetes women, 4 out of 36 women did not require any insulin for the first 12 hours postpartum. And the longest period was actually 28 hours in that study. And 75% of women who had C-section also required, without insulin, but required sugar, dextrose intravenous infusion after the delivery. And 80% of women actually do require less than pre-pregnancy for the next 48 hours. So what we usually do is when women delivers, when we start the pump back, we start at 50% of the pre-pregnancy dose. Again, everyone can be different, but this is just general sort of recommendation. And for breastfeeding, we talked about this a little bit. So glucose, about 50 grams of glucose is ingested or consumed, is diverted to the milk production, to the process, to the milk synthesis and secretion. And therefore, the insulin requirements go down because that part of that glucose is used for the breast milk production. Plus, so sort of more burning those calories and sugar during the breastfeeding process. Therefore, that the insulin requirements go down significantly. And it's important to increase caloric intake, so after delivery and during the breastfeeding. So we actually did an interesting study. So we looked at the caloric requirements for women before and after delivery, and by measuring basal metabolic rate. So we had this fancy machine that one of the companies sent us. And the women who required before pregnancy required anywhere from 1,600 calories per day. After delivery and during the breastfeeding required 3,000 plus calories per day. That's quite impressive. And I think usually it's a great time. With my personal experience, I think I was eating whatever I could possibly eat and I was not gaining weight. So while breastfeeding, but it stops abruptly after you stop breastfeeding, all the way then comes back up. So that's
I found that I gained more weight because I was so conscientious of being type 1 during my pregnancy that I gained more weight after while breastfeeding because I felt like I needed the calories and more, I was more hungry and didn't have to worry about it as much. One of the questions I've seen a lot, if you can answer, Dr. Basina, is if your blood sugar is high, can you still breastfeed your child?
Yeah, you can still breastfeed your child, absolutely. Yeah, so it's more dangerous actually if your blood sugar is low to breastfeed your child, right? Because that further drops your blood sugar. So you would need to have a little snack and sometimes completely discontinue or stop the insulin for the time of breastfeeding or even before breastfeeding to avoid this low blood sugar. Yeah, but if your blood sugar is high, definitely you can do it. So challenges with the tight control, severe hypoglycemia is more common, especially during early pregnancy, as we talked about. Up to 45% of women experience severe hypoglycemia during the pregnancy, especially before the week 20, and then less common afterwards. So the incidence lowest in the 3rd trimester when insulin resistance goes up. How do you achieve this 140 target after the meal? So the recommendations are, in order to try to avoid extra insulin, if you have time, if it's practical for you, for your lifestyle, if you can just finish eating and go for a walk. So there were studies done and looking at what if you do walks 15-20 minutes after each meal, and that significantly reduces your insulin requirements and significantly improves your time and target for the post-meal blood sugar. Avoidance of severe hypoglycemia is important during those exercises. So this is similar what I already talked about. For the postpartum, the insulin dose requirements decrease by 50 to 60%. But there could be considerable variability. And again, after delivery, we start with pre-pregnancy dose reduced by half. So that's usually recommendations, but again, could be different for everyone. For the breastfeeding recommendations, increase your caloric intake by about 500 kilocalories per day. And we talked about how much of glucose does go in for the milk production in women. I'm going to skip that part. So for the low blood sugar prevention, proactive insulin reduction, usually by up to 20%, those weeks and the end of the first trimester when you're most insulin sensitive, you can reduce safely by at least 15 to 20%, and usually it's even more, and then start going up thereafter. Precaution use of supplementary insulin. So even if you're high after the meal. Don't give yourself too much insulin for correction, because again, those correction doses cause the insulin stacking, and then you will be lower later on. Use that as an information, as your FYI for tomorrow, because you would know that that particular breakfast is something that raises my blood sugar significantly. So next time tomorrow, I'm going to take 2 units more for this particular breakfast. It's useful to have sort of similar foods during pregnancy. You don't have to do it through the whole pregnancy, but one of our nurses actually at the hospital, she was working full time during the whole pregnancy, and she usually her go-to breakfast was breakfast burrito at our Stanford cafeteria. And when she was pregnant, she was going to every day. She was going to the same cafeteria. She was getting 2 hard-boiled eggs, and she was texting me those pictures of that breakfast with the toast. And she said, I go every single day. I smell this burrito. I get those 2 eggs and toast, and I leave cafeteria. And as soon as she delivered, she sent me a picture of her with this huge burrito in the hand. So she was so happy that now she can have this burrito. So again, because it's such a limited time in life, so it's important just to try to sacrifice a little bit for just that period of time, because that's important for the baby. Always carry some source of sugar with you. It's super important for, it could be either some milk or some juice or glucose tablets. I usually like the glucose, something that glucose is chewable and can absorb through the mouth, because the stomach emptying and the absorption from the stomach could be variable, because the stomach is raised, the diaphragm is raised during the pregnancy with the growing uterus. So I think whatever is faster absorbed from the mouth, that's always easier. And even mentally, when you have that sugar that you're chewing, you feel better than you just gulp this juice and wait for the effect of this juice. So avoid going to bed with blood sugar less than 110. Frequent monitoring, use of CGM, using the either loop or Control IQ or the 670G Medtronic with suspend before low. So you cannot use those commercially available systems. Unfortunately, are not designed yet to be used during the pregnancy. So there is an ongoing study with use the Control IQ during the pregnancy. Dr. Carol Levy is trying to, she's just started about 2 months ago, I think earlier this year. And also with comparing with the loop. But as of now, those Control IQ and 670G or commercially available closed loop systems are not allowed to be used during the pregnancy because targets are higher. So we're not using them during the pregnancy. So again, exercise is important. Do walking, do whatever you can for exercise. Avoid the low blood sugar during the exercise, but that reduces your insulin requirements significantly. And just to quickly summarize, so healthy pregnancy, starts planning before conception. It's challenging, but it still should be enjoyable time, and it should be still a great time when, especially when you're looking back, you're thinking, oh yeah, that was actually a good time during my life. So I was so greatly controlled. I was so disciplined, like I could never do it before or after the pregnancy, right? Because your brain is all devoted to that little growing inside the body. And that diabetes should not stop women from experiencing from having this great experience of having children. But again, educate yourself as much as possible, make some commitment. Again, this is if you really like those, cookies or cakes, just choose the one that you know that you can cover and you know how to cover, and just have that sweet for your pregnancy, or a few different things that you would know you already tried and you know how much insulin to cover for that. But the rest of your stuff leave, till after delivery. And then put your baby first while you're pregnant. Again, it's such a out of the lifetime, it's a short period of time. So just try to concentrate on that and have the enjoyable experience. And happy to answer any questions. Sorry, I think I went over time.
Thank you, Dr. Basina. That's fantastic. We always appreciate your knowledge around diabetes and pregnancy. So thank you. Does anybody have any questions for Dr. Basina? Is there anything that you feel wasn't touched on or you'd like to know more about?
I have one question. During delivery, how is blood sugar monitored? Like, would the nurses check the Dexcom, or do they check you every half hour, or how does that work?
So they do check you every 30 minutes per our protocol. They check every 30 minutes. So the Dexcom is, as we talked about it, especially if the blood sugar is changing up and down, the Dexcom will be about 10 to 15-minute delay, especially if the blood sugar changing rapidly. If they are going up or down 3 milligram per deciliter per minute or more, right? So for this 10-15 minutes may turn into the, good number of the difference between the finger sticks. So per our protocol, it's being monitored every 30 to 60 minutes. Yeah, and that's why I know that a lot of women would say, no, they're taking my pump away and I don't want to be off the pump and I don't want to be on the insulin drip. This is horrible. But if you think about the physiology, again, it's so much easier to achieve the control as we would to avoid the lows, to get faster to that control with the IV insulin than with subcutaneous insulin, because again, absorption could be variable, stress level could be variable. There could be subcutaneous tissue swelling at the end of the pregnancy, could be variable, right? Because a lot of women would be having some leg swelling and the body swelling during the pregnancy. So it's just medically so much easier and safer to do. So that's why I'm personally all for it. But I know some women would just say, no, I really want my pump. And again, we compromise that and we say, sure, just stay on your little basal rate throughout the pregnancy so you feel that you're under control. I think for some women, it's super important just to feel that I still have it and I still, yeah.
Right, and some hospitals, unfortunately, though, won't allow it at all. And so Stanford might have their protocol like that, but other places, and from experiences I've heard, it will be absolutely not whatsoever. Other places will allow you to sign a waiver. And generally when it comes to blood sticks, it tends to be that the hospitals like to use their own machines, meters. So I've kind of always negotiated, well, can I use my own Lancet, please? Because I feel much more comfortable than the hospital ones.
Oh, hospital Lancets are horrible. So definitely request your Lancet. Yeah, I always they are horrible. Those are the Lancets actually that we use, the same one we use at the camp. For kids, which I feel so bad poking the kids at night with those horrible Lancets. They're so painful.
Oh, that's sad. Maybe they can have like a little bag with their name on the side and you guys can just grab and use their own. But I know it's not, you have to change the needle every time. So it's just easier. Is there any other questions for Dr. Basina?
A quick follow-up. So does the woman or the mother kind of get a break from managing her blood sugar, like while she's in delivery? Like, is the doctor and nurses taking care of all that?
Yes. So usually if you go on IV insulin, then they take over. And we usually ask, like after women delivers, because we're not as, careful about, we don't need that tight control after delivery, and actually insulin requirements go down significantly. Some women would say, I just want a break. I don't want to be on the pump for the next couple of days that I'm in the hospital. I just want you to take over and just do my shots. So the nurses would be, and we will just write the protocol and the orders, and the nurses will do the shots. Yeah, a lot of women would say that I'm just tired, or after C-section, I'm still sleepy, and I just want to just get a break, and that's totally, absolutely fine. Yes, so then nurses will take over and they will do the shots. So you can still use your Dexcom, you can still use your sensor, but they can take over and do the injections.
I think it's a great time to have your spouse involved, though. If you want that break, to have them understand and know your diabetes a bit more, where you're at. I did have an experience of a nurse wanting to give me insulin when I was 80, and I was like, being able to jump in at those points. So I'm somebody who likes to be in the know a little bit, because especially with shift change, and not everybody has the same experience with type 1. So people do want the break, but it's like, you really, if you want the break, then have your spouse kind of know what's going on, and maybe he can check in with the nurse for you to say, well, okay, well, how much are you giving her? You don't have to be involved in it, but just so that like you're not getting overdosed when not necessary.
Makes sense.
Yeah, for sure. It's always good when somebody overlooks the overcare, that's for sure, because you never know who's going to be ordering what.
Awesome. Well, thank you so much. Anybody else have any other questions?
I have a question. I heard you saying a lot about C-section. Is it a requirement for type 1s? The
Oh, definitely
C-section?
not. No, definitely not. So it's
Okay.
yeah, for some, it's just the regular indications. The type 1 diabetes does not increase your requirement for having C-section. It will be OB indications for if there are OB indications for C-section. But no, absolutely not. No, most
Do you,
women will
so
have
do you have, and regards the gynecologist, are there requirements? Because I see here in Brazil, friends of mine who got pregnant and they are type 1s, and they said that it was very stressful to deal with the gynecologist because they didn't understand much about type 1 diabetes. So they were afraid of complications, so they were pushing them to have a C-section or to do something, because they were scared, right? So do we need to have, we talk about the healthcare team, like, is there a need that we have a team that specialized in type 1 diabetes?
Ideally, if you have that team that is close and to the institution that you can go for care, I think that's important to have the team that knows about type 1 diabetes, or at least to have one member in the team who would know. And if there is no, if the OB team, for example, does not have a great experience, if there is someone who is, willing from the team to communicate with your endocrine team, with your diabetes educator. So I've had sometime during the delivery, the dads will be texting and saying, oh, this is what's going on and this is what's happening with the blood sugars. What do we want to do? And sometimes the doctors, the OB doctors or nurses would be texting you or paging you during the labor and delivery. So yeah, as long as your team is willing to work with your diabetes team, that even if the OB team is not that experienced with type 1 diabetes, would be fine too.
Yeah, I've seen that. So I'm also involved with the Spanish-speaking women who live with type 1 diabetes and pregnancy group. And a lot of the countries, the moms I've seen in Latin America, the hospitals are really pushing for C-sections. And that's the only way that it's possible. So I've had 5 natural deliveries. They've all been inductions. When the first time I got pregnant, it was protocol for all type 1s to be delivered at 37 weeks. And then they moved it to 38 weeks. Now there's women delivering around 39, but it's definitely not mandatory to have a C-section. So I'm proud that I've had 5 natural deliveries, and the 4th one, he was so big, we did it at 37 weeks again, just so I could maintain that. So I think, like Dr. Basina says, find the right team that's willing to work with your endocrinologist.
Yeah, thank you. And yeah, you're right. They push for C-sections. I don't know the reason, but it's important that we know we have the choice, right? So
absolutely, and I know that you can stand up for yourself, and that's why it might take you some time in the beginning, and make sure those are some of the questions that you ask, and then say, okay, thank you, it was nice to meet you, and maybe move on and ask if you know other type 1s down there, or that are your friends or personal people that have gone through natural deliveries. Just seek out that right team, and always advocate for yourself, because a lot of times people get feared into thinking this is how it has to be, but that's not the case. And self-advocation is a huge part of living with type 1 diabetes and pregnancy.
Yeah. And if you want to connect with someone with type 1 diabetes who is from Brazil, we can do it. So we have women in the Sugar Mamas group.
Oh yes, we do. She just had a baby in December or January.
Already had the babies. Yeah.
Thank you, girls. You're awesome. And how do I follow you on Instagram?
It's at here. I'm gonna go ahead and put it in the chat for you.
Okay. Thank you both. Thank
You're
you.
very welcome.
Thank you, doctor. It was a great presentation. If that's okay, I took some print screenshots because I have a friend who is pregnant and I want to share with her. So,
Of course, yes, for sure.
thank you.
And I have my email too, so feel free to email me with any questions.
Thank you. Thank you so much.
So I put in the notes, so there's at T1D Sugar Mommas on Instagram. Our Facebook group is T1D SM Private Group, and there you'll find more conversation. And then you can also go to our website coming up. You can put your email there and be notified when we go live. Hopefully that will be in a few weeks, but we have multiple different resources. We're always looking for women to contribute their stories, and for dads too. We've had our first dad yesterday who lived with type 1 who had questions about parenting, and he joined our conversation. It was fantastic because he's such, I mean, we do a lot of the work through pregnancy, but there are dads who live with type 1 as well. Any questions?
Spouses of women with type 1, I think, need to be, or a special group, right? Because that's a lot of challenges as well.
Yeah. So I'm putting, Dr. Basina, I just emailed your email address to everybody.
Sure.
In the chat, so you guys can copy that down. And anything Sugar Mamas can help you with or you'd like to see us more talk about, please let us know. And there's our email address for that. Is there any other questions for either of us?
I had a, I think you answered saying we can't do control IQ with pregnancy.
Yeah, unfortunately. So for women who are planning on getting pregnant soon, and before downloading your control IQ, stay on basal IQ because you can still use.
I was in the study at Stanford, and then now I have my own. So I love it, but now I'm like, oh no.
Yeah. So that's unfortunately. Although, again, I think that maybe the study will come out and maybe it will show that it's safe because the control, I mean, you're trying really, really hard and it's super difficult to achieve that super tight control. So I think the control IQ really doing a good job. And, but technically because it aims for the target of 110 and the ideal target for fasting should be lower than that. So that's for that reason it's not allowed. But
I think this might help you a little bit. So I'm not on control IQ. I actually didn't even use Dexcom because I didn't feel a G5 was ever a good fit for me. So I didn't even use it until my 5th pregnancy. And I actually, I did the do-it-yourself looping through my last pregnancy. And I actually found, because, you know, there's a little bit of a delay and everything, it could not keep up with me. It has worked for some women, but it could not keep up with the consistent changes. So the biggest relief that I found was I would keep closed loop at night and then I could wake up, you know, at a really great fasting number, but throughout the day, introducing food, the ups and the downs, there was too many swings. So I ended up having to not loop during the day, leave it open, adjust myself, and then use it part-time.
Okay, that's a good suggestion.
Yeah, and somebody in the chat actually asked about, can we use the loop? Yes, absolutely. Just important, like Brooke said, to know the physics of the loop. Loop is great because you can personalize your settings and you can use whichever settings you want for your target. So there is a little trick with the loop that you have to have kind of lower basal rates with the loop because the loop will suspend if you put lower target and your basals are a little bit too high. It will suspend, and then if you have it counts as this negative basal for whatever time your suspension, it will count as this negative insulin on board, and then it gives it back to you when you're on the when you're getting back to your target range, and then you can go back low again pretty quickly. So if you are on the loop, look at there are great articles from Katie DeSimone on cmycgm.com. That's where she describes those specifics about the rates and about the loop, and compares actually loop with control IQ, and she, you know, the algorithms and what the differences are. So again, the key is just to have your basal rate low enough so you won't be suspended too many times. Because if you're suspended too many times, the time that you're suspended, loop counts as negative insulin on board, and it adds it back on as soon as you get to a target. So that's one kind of disadvantage of loop. So, but just again, just this setting adjustment. But yes, during the loop of that pregnancy, you can use the loop if you have the appropriate pump.
Right, and there's also Sugar Mommas is great, of course. I'm always going to promote us, but there's also a fantastic Facebook group, Looping in Pregnancy. So you'll find all moms who are do-it-yourself looping in that group as well. I'm a part of it, and it's been fantastic. It's great to see those numbers grow as well because you know the technologies are changing so much. And if I had this, I mean, you know, for my first pregnancy. I mean, it would have been phenomenal, but it's really allowed me to have the experiences of testing 15, 20 times a day, you know, being afraid to go to sleep because my blood sugar wasn't going down and you know, adjusting my diet or, you know, dramatics to my husband, look at me. I mean, it is, like Dr. Basina said, it's an emotional process. And as I've gone through each pregnancy, I've gotten a little bit more relaxed about it. And I'm like, okay, I got this. It will come down eventually. It's a site change or, okay, I need more insulin. Oh, I need to adjust my insulin requirements again. So having the relationship with the doctor helps with that as well.
And again, more conventional technology, more FDA technology is coming out. That's what Dr. Buckingham is talking now about, what's in the horizon. So there are several pumps that are coming out with adjustable targets. So even Medtronic is coming out with adjustable target with target 100 or 120. Some of those studies we did at Stanford, and Horizon trial with the Omnipod hopefully will be coming out soon. So there are things on the market that are coming out within the next year. So if you're planning on pregnancy, if you're not thinking about right this minute, but in the next 2 to 3 years, realize that there's a lot more stuff that's coming out that is commercially available.
Fantastic. Any other questions? I've really enjoyed getting to know all of you, Dr. Basina. I always love chatting with you and your knowledge about diabetes and pregnancy and diabetes. So thank you so much for your time. Paige, thank you for hosting the room. And again, you have all of our contact information. I'm always happy to try and help connect women and people who live with type 1. If I know somebody somewhere, I was like, hey, meet this really cool person. So if I can help you with that, and if I know somebody, I'm more than happy to do that. If not, then I'm going to go ahead and say goodnight. I'm a couple hours ahead of you guys. Going to go get the kids in bed. All right. Well, thank you all very much for your time. Dr. Basina, thanks again.
Thank you. Thank you.
And I look forward to hearing from all of you.
Thank you all.